Good afternoon, everyone from Geneva. My name is Sheila Anazonwu, and I'm the IHF Partnerships and Project Manager. And I do welcome you all on behalf of Eric de Redenbeck, IHF CEO, to this webinar, the second that's been hosted since the launch of this initiative this year. We do have 3 to 4 of such events planned per year, and the topics of which are IHF Congress or event related. To perhaps give you a quick background as to this event, the main purpose of IHF introducing webinars to its repertoire of activities is so as to provide our members and also non-members with additional education tools, and also enhance IHF's information sharing capacity. And lastly, also to stimulate and promote peer interaction, in particular from grassroots levels upward. So for this event, we are indeed very pleased to welcome Dr. Gerard Rockenschaub, who is Project Manager, Country Emergency Preparedness in the Division of Communicable Diseases at the World Health Organization Regional Office for Europe in the Health and Security section. Dr. Rockenschaub, in his presentation entitled Safe Hospitals, Essential for Emergency Preparedness, will briefly introduce such tools as the Hospital Safety Index, the Hospital Emergency Response Checklist, and the Toolkit for Assessing Health System Capacity for Management, which has been developed by the World Health Organization for the purpose of assisting emergency managers to assess structural and functional safety in health facilities. Dr. Rockenschaub also will provide us with an overview of the implementation and rollout in member states of the World Health Organization European region, with the objective to enhance emergency risk and crisis management capacities of hospitals, and also to strengthen overall health system preparedness with all hazards approach. Just a little bit of information. Dr. Rockenschaub's, after his presentation, we will allow a 2 to 3 minute pause, which will allow participants to, using the comment button, which is the first button on your left, will allow you to field questions, which will be answered by Dr. Rockenschaub verbally. So, Dr. Rockenschaub, thank you again, and the screen is all yours.
Thanks very much, Sheila, and thanks for the International Hospital Federation for inviting me to this webinar. I think it just underlines the important partnership between the World Health Organization and the International Hospital Federation. And Sheila, please jump in if there is any problem with technology, because frankly, colleagues, we did have quite some challenge in setting this up. So I hope that technology-wise we will be fine for the next half hour or 45 minutes or so. I'm just briefly, as Sheila mentioned, and thanks also to Eric Rodenbeck for organizing this, I will briefly go through some of the WHO tools that we have developed to particularly help hospital managers to strengthen emergency preparedness and disaster resilience of their hospitals and health facilities, but also then would like to refer to some of the other tools that we as WHO try to promote to strengthen emergency preparedness of health systems overall. And last but not least, at the end, I would like to highlight a fairly new agenda that we are trying to promote, which is the standardization of field hospitals or foreign medical teams that are deployed to support international relief operations in acute disaster situations. So just that hospital managers and the International Hospital Federation is also familiar with that area of work. Now, safer hospitals, to start with, is not an essentially new topic It has been on the agenda for quite some time, not only promoted by WHO, but by other UN agencies like the International Strategy for Disaster Reduction and the World Bank that initially have been promoted safer hospitals. And then in 2009, we had the World Health Day dedicated to safer hospitals and disaster resilient hospitals as well. And you might be also familiar that at the moment we are in the run-up to the next big conference for disaster risk reduction, which is going to take place in 2015 in Sendai. And indeed, we from the health sector and from WHO are pushing that safer hospitals keeps high on the agenda of this multi-sectorial framework for disaster risk reduction and emergency preparedness. Let me maybe just briefly reflect on WHO's objective in our emergency work in general. What we are trying to do with our work in member states, with health systems managers, with policymakers and with hospital managers is really to reduce emergency-related mortality and morbidity, aiming at building resilience and strengthening health systems through an all-hazards approach to preparedness planning, engaging multiple sectors, all sectors that are involved in supporting the health sector in the emergency work. We do that within the context of the international health regulations, which is a legally binding framework that requires member states to share any potential events that could create or trigger a public health emergency of international concern with WHO, and to do a joint risk assessment in order to be able to respond very quickly at the onset to prevent events from even developing into a public health emergency of international concern. And when it comes to responding to international humanitarian crises, big disasters, then WHO is also the health cluster lead agency in charge of coordinating jointly with national governments and ministries of health the international humanitarian health response. Just to quickly look at the context, why is WHO at all engaged in emergency work? Well, at any given moment in time, we have 30 to 40 of our member states affected by a crisis, by a disaster, by a conflict, by a humanitarian emergencies. We also see, as these two graphs indicate, an increasing number of disasters with increasing health implications of disasters. We also see increasingly complex environments in disasters. Just looking at the Syria crisis, the Ukraine situation, the floods in the Balkans, or at MERS or Ebola, if looking a bit into the context of communicable diseases. And we also see increasing expectations from the health side, also from WHO. And health is always a major concern in all emergencies and disasters, with infrastructural damage affecting hospitals and the health system at large, and with health staff also being affected and unable often to provide essential and life-saving services. Just to look a bit at what are actually the facts and figures regarding disasters affecting the WHO European region. I myself, I work here in Copenhagen, and we are covering the 53 member states of the WHO European region, which extends a bit to geographical Europe in geographical scope. So we also cover all former Soviet Union countries like Central Asia, like the Caucasus countries, and also Turkey, Israel are part of the European region in the WHO regional distribution of countries. So looking at the disaster situations affecting the European region member states in these 22 years of observation, some things that strike out a bit is the very high frequency of disasters, which are by far the most frequent event, floods, which are by far the most frequent events affecting our member states. The very high mortality attributable to extreme temperature events. Much of those more than 138,000 deaths are attributable to heat waves that affected Western European countries. Also, we have a rather high mortality attributable to earthquakes, over 22,000. And in total, we have 2,200 events triggering more than 192,000 deaths and affecting close to 48 million people in this observation period. So just the key message here is that, yes, disasters are an issue also in our region, where many of our member states are actually EU member countries. So even in a strongly developed health system context, like in Western European countries, we do face quite some challenges with disasters and emergencies affecting and challenging the health system overall. What we try to do from our WHO perspective is really to try to address all these emergencies, disasters, be it pandemics, health crises, natural disasters, conflicts. We do promote an all-hazards generic approach to emergency preparedness planning to be better able to address the health challenges. We really want to move towards a comprehensive emergency risk management framework to help us and to help particularly our member states to better address the health challenges of emergencies and crises. Now we are building this strongly on a common operational platform for all of WHO's emergency work across all aspects, building on the emergency response framework to strengthen our own, but also the response capacity of member states, but then going beyond the response also to effectively address prevention and preparedness efforts, including the post-Hyogo framework for action, the international health regulations, the pandemic influenza preparedness framework, and the Safer Hospitals initiative as one comprehensive framework to address all aspects of emergency and disaster risk management framework for health. We really tried to promote this evolving paradigm for emergency risk management for health and to move from an event-based to a more risk-based approach, from a more reactive, response-oriented mode of operandi to a more proactive, prevention-oriented approach, from a single hazard to an all hazards approach in preparedness planning, from a hazard focus to a vulnerability, capacity and resilience oriented focus, also in terms of addressing the challenges at the health facility level, from a single sector, single agency mode to a multi-sectorial whole of society approach in emergency preparedness, and from a response focus to a risk management focus, addressing all the elements in the disaster and risk management cycle, from prevention, mitigation to response and recovery and rehabilitation. And safer hospitals, disaster resilient, well-prepared hospitals are of course an integral element of this approach and a global as well as a regional priority for WHO. What do we want to prevent with this safer hospitals approach is actually dysfunctional hospitals and health facilities that collapse and fail in disaster situations and emergencies and are then unable to provide essential services to their communities, to save lives and to effectively protect their communities that they're an essential part to serve. What we want to promote with this safer hospitals concept is that all new hospitals are designed and constructed in a way that they withstand disasters, and hospitals in generally are managed to function at the optimum capacity during and in the aftermath of disasters and emergencies. And that includes well-trained staff that are proficient in emergency management, not only in managing individual health emergencies, but also managing a large extra workload that is usually typical in mass casualty events in disaster situations. We want to promote norms, guidelines, and building codes to be implemented for the construction of all new hospitals, and that existing priority health facilities are retrofitted accordingly so that they can withstand severe disaster situations, of course, with an emphasis on low-cost, high-impact interventions. One of the tools that primarily were developed by initially the Pan-American Health Organization is the Hospital Safety Index, a WHO tool to help emergency managers, hospital managers, but also policymakers to assess the structural and functional safety of health facilities. We in the European region, we have rolled out these hospital safety assessments in 12 European countries. Globally, it's rolled out in many more countries and has really developed as the global standardized tool. And more recently, we have also jointly with the International Hospital Federation and with their technical input revised this global tool, and there is currently a revised tool in the final development stage that will be rolled out right in time for the new disaster risk reduction conference in Sendai that is going to happen in 2015, early 2015, March 2015. I wanted to just give you a brief example of the implementation of this hospital safety index in one of our European member states, in the Republic of Moldova, where we have jointly with the Ministry of Health rolled out this hospital safety index assessments in all 66 hospitals and health facilities nationwide. And it provides a quick overview about the structural, non-structural and functional safety and capacity, ranking the assessed hospitals in low, average and high levels of safety and capacity, and so gives policymakers a quick picture what are the priority facilities that really won't be able to perform effectively in emergencies and disaster situations, and try to initiate priority actions to address the shortcomings of those facilities that have low structural and non-structural safety levels and low functional capacity. Hospital emergency preparedness is, of course, crucial. It's not sufficient to only address structural and non-structural elements. We also need to include hospital emergency preparedness into this comprehensive package, as hospitals, of course, play a critical role within the health system in providing essential medical care to their communities during normal times, but even more so during emergencies and disaster situations. And in large-scale emergencies, crises and natural disasters, we really require a complex response efforts, with health being of primary concern. And often what we see is that hospitals already under normal circumstances operate near maximum capacity. So we really need to plan for adequate surge capacity, but also for hospital networking, allocating patients accordingly in mass casualty situations in order to be able to address the health challenges and the increased demand and patient load in disaster and emergency situations. I wanted to quickly refer to this WHO European tool that we have developed, the Hospital Emergency Response Checklist, which was developed to support hospital managers and emergency planners in achieving continuity of essential services while responding to large-scale events. It highlights in 9 key components what are some of the key essential elements that need to be addressed in order to ensure that the hospital remains functional at optimum capacity during a large-scale emergency, during a disaster situation. I won't go into the details here, but it addresses issues, critical issues like triage mechanism, surge capacity, continuity of essential services, and it's downloadable through this link. We have it both in English but also in Russian language, and did also translate it to several other languages. So it's available as a quick and dirty tool, just highlighting some of the key elements for hospital managers that they should consider addressing to be able to respond to large-scale emergency situations at the hospital level. Of course, hospital preparedness needs to be integrated as an essential element into the broader crisis management system of a country. And in order to promote that, we have developed the WHO Toolkit to assess the crisis management capacities of the health system at large, a tool that identifies the strengths and the weaknesses of the emergency management capacity at the national and the local level, but also tries to identify some critical gaps so that we can plug in some capacity building measures to be able to address the identified gaps jointly with ministries of health and health emergency managers accordingly. We have rolled out this assessment in so far 16 countries in the European region, from pilots in Armenia, Azerbaijan and Moldova, then also applied it in several EU countries like Croatia, like Poland, and did also a self-assessment approach in countries like England and Israel. It basically just provides a structured approach in looking at health system preparedness from a broader perspective and trying really to identify strengths and weaknesses, and also try to compare or give good practice examples like the report from the England health system preparedness, which we did, by the way, in the context of working with Public Health England and the Health Protection Agency at that stage in the preparations for the London Olympics and the health system preparedness efforts for this mass gathering event. This is just to share some of the complementary tools that we have developed, some also looking at emergency medical services arrangements in EU member states, just to complement the tools that I was already mentioning. Just to wrap up on the safer hospitals issue, I think we really need to stress and underline that this is really a multi-sectorial challenge, that the health ministry cannot be left alone. It's really a joint responsibility that requires the support and also the input from other sectors, from security sector, from energy supply sector, so that we can jointly ensure that health facilities really receive priority attention when an emergency occurs, and that we consider them as a critical infrastructure within the multi-sectorial crisis management arrangements at the country level. I wanted to, show you a slide or two on our emergency response work, so that also to give you a bit of a brief orientation what WHO in the regional context is doing in supporting member states in concrete emergency situations. We have, by the way, right next door from where I'm sitting, we have our WHO Europe Emergency Operations Center here in the UN city in Copenhagen. You see here in this picture the formal opening where Ban Ki-moon, the Secretary General, together with the Queen of Denmark and the Prime Minister were visiting our center. It is really a regional hub for emergency preparedness and operational support to manage public health events and humanitarian crises, and it's activated as per our emergency procedures here at WHO Europe. At the moment, we are dealing with 3 separate, different, unique emergency response operations. One of them being Ukraine with the conflict involving there primarily in the eastern part of the country. We also were dealing with the Balkan floods, or are still dealing with the Balkan floods that affected Bosnia and Herzegovina, Croatia, and Serbia. And then, of course, we're quite heavily involved in Syria in trying to address the refugee situation in southern Turkey. And in fact, we have a humanitarian office established there in Gaziantep at the Syrian border that has a number of WHO staff working with the Turkish Ministry of Health and with hospital managers in trying to address the additional workload triggered by some 800,000 Syrian refugees that are currently accommodated in Turkey, giving quite an extra challenge and workload for the Turkish health system there. In terms of the Balkan floods, I mentioned that already. Part of it was quite substantial infrastructure damage to the health infrastructure, primarily to primary healthcare facilities, not so much to hospitals. And we tried to address that jointly with ministries of health to do a sound damage assessment following the acute emergency response. A post-disaster needs assessment was conducted both in Bosnia and Herzegovina and also in Serbia that tried to quantify the financial losses due to the infrastructure damage, and those reports will be submitted to the international donor community once this needs assessment is finalized. And I mentioned the Syria crisis and the challenges for hospitals and health facilities and the health system at large in Turkey. Just to mention that Turkey is actually excellently managing and all Syrian refugees or Syrians under temporary protection in Turkey are offered free of charge health services in hospitals. But of course it's creating quite an extra burden for the Turkish health system to manage the extra workload in association with this huge refugee wave coming from Syria into southern Turkey. I mentioned that at the beginning, I wanted to, at the end of the presentation, really quickly reflect on this potential aspect of future collaboration between the International Hospital Federation and WHO, which is really promoting the registration and standardization of field hospitals and foreign medical teams that are deployed in sudden onset disasters. This is a piece of work that primarily came out after the Haiti disaster, where the deployment of foreign medical teams without the required international standards created quite some challenge at the national level. Just one example was the lack of standards for amputations there, which really created quite some problems for the local population because amputations were done often on an ad hoc basis and the decision-making criteria and standards were not really clear. So there was a clear need for WHO to become involved in terms of our promoting our standard setting work in trying to come up with some standards for future field hospital and foreign medical teams deployment. If we look at some of the evidence in that connection and the burden of disease that we are actually seeing in disaster situations, I just wanted to briefly familiarize you with this slide because what we're seeing usually in post-disaster situations in terms of the morbidity and mortality is really four waves rather. There is an initial wave in the very immediate stage that is really primarily a peak in trauma cases, also in trauma deaths, particularly in earthquake situations, which is usually happening between the days 1 to 3. So that's often not even addressed by foreign medical teams and needs to be dealt with by the local health system that is already overburdened. Because usually field hospitals and foreign medical teams, even in the best of circumstances, won't be able to arrive before day 3. But what is important is that the second wave that we see is usually primarily wounds and orthopedic cases, but also surgical emergencies. So it really gives us an indication that foreign medical teams and field hospitals not only need to be capable to deal with trauma cases, but really need to have broader surgical capacity engaged. And the wave 3 that is then followed is really surgical, more specialized surgical cases, and particularly infection-related cases, but then also increasingly conservative cases. And then the fourth wave that is the one that really corresponds to the background surgical cancer and non-communicable disease cases. So when planning for standards and for the deployment of foreign medical teams, it is very important to keep in mind these burden of disease waves, so that we are not only capable of only addressing trauma cases, but usually should include broader surgical capacities, but also being able to look into being able to address infections that are associated with those trauma cases, and then more broader surgical capacity to be able to also cover the third wave. When looking at the expected effects in natural disaster situations, it's really earthquakes that are very high in triggering severe injuries and requiring complex treatments, whereas strong winds, hurricanes, typhoons, and also then tsunamis that occasionally are associated, like the typhoon Haiyan that we experienced, or Yolanda that we experienced in the Philippines recently, which was sort of a bit of a combination of almost a tsunami-like situation and strong winds that are less strong on the severe injury side, but still require, of course, strong surgical capacity. But just to make the key message and the key point here, it's really beyond search and rescue, the capacities that foreign medical teams and field hospitals need to be able to address. It's broader surgical capacity that needs to be included. So this work on trying to standardize and classify foreign medical teams was conducted jointly between health cluster partners, global health cluster partners, and WHO, and came up with the classifying foreign medical teams into type 1, type 2, type 3, and then additional care foreign medical teams. Basically, the type 1 having primarily outpatient emergency care and referral capacity, type 2 integrating inpatient surgical emergency care capacity, and the type 3 then also including inpatient referral care. All these three types have minimum standards that are included in order to ensure that we don't end up deploying two-person teams that are, of course, not able to meet the challenge of at least treating at least 100 outpatients per day in the immediate aftermath of a disaster situation when they are deployed to provide international support. And this foreign medical team classification are linked to some core standards that apply to all of the categories I mentioned earlier. Of course, within the core standards, all of the foreign medical teams need to agree to register with the relevant national authorities. They need to agree to regular report that they have confidential medical records capacity, that they record the treatment with an appropriate medical record system, that their medical professionals are registered and licensed for the work that they are assigned to by the agency, that they have appropriately trained, pre-qualified staff, that their pharmaceutical products and equipment complies with international standards, that they are deployed to be self-sufficient for a prolonged period of time, and that they, of course, adhere to minimum hygiene and sanitary standards. I just wanted to briefly familiarize you with this. The background document is downloadable through this link I have provided on this slide. I know it might not be immediately related to the work of hospital managers, but eventually all the professional staff that are deployed with foreign medical teams, with foreign field hospitals, are usually working in hospitals. So I just wanted not to miss the opportunity to familiarize you with this work, with this agenda on WHO, to try to standardize and then eventually promote the registration through building a registration system for foreign medical teams. The next steps, of course, being then to promote these mobile hospitals or foreign medical teams also for strengthening the national response capacity, to use those teams also to support the health system during surge and early recovery. Of course, they are not only meant to be deployed internationally, but also to be deployed nationally to complement damaged hospitals if the building infrastructure, despite the Safer Hospitals initiative, still can sustain deploying national teams, medical teams and field hospitals might be an option to strengthen a damaged infrastructure. And we are trying to promote a regional rollout. I mentioned the background documents are available through this link. I think with this I'm coming to the end of the presentation. I hope I wasn't too long and too boring. And I'm, of course, ready for answering any questions and to try to clarify any unclear issues. Thank you very much for the attention.
Thank you very much, Dr. Rockenschaub. I would like to just invite all participants to now send through, we'll take it the next minute or two, to have you send through questions by, as I mentioned, using the comment button, which is on the bottom left, to which Dr. Rockenschaub will respond. Thank you very much. Dr. Rockenschaub, we have two questions.
Yes.
We have from a Louise Wood, who is asking, are there collaborated efforts outside the EU?
Yes, if I can respond to that quickly. In fact, I mean, our primary effort, or let's say our priority, is usually to support countries outside the EU, particularly in the area of emergency preparedness, for the simple reasons that countries outside the EU, at least in our region, have much less resources available than EU member states as such. Now, having said that, I mean, we collaborate primarily. I mean, we have quite a heavy focus on Central Asian countries like Tajikistan, Kyrgyzstan, where first of all the risk for natural disasters is quite high and resources are quite limited. We also work quite substantially with the Caucasus countries. Moldova, I mentioned. We have a very extensive collaboration with Turkey. So yes, there is quite extensive collaboration with countries outside the EU. Then, of course, I speak from a European perspective because I'm here at the regional office, but of course there is extensive collaboration through the other regional offices, but also through WHO headquarters in Geneva, ongoing with countries outside the EU that is coordinated by other regional offices, the Pan American Health Organization based in Washington, by the Southeast Asia Regional Office based in New Delhi, and by our Western Pacific Regional Office based in the Philippines, in Manila, and also by the Eastern Mediterranean Regional Office based in Cairo that covers North Africa and the Arab countries primarily, and then of course by our African regional office based in Brazzaville, covering the Afro countries, and PAHO, the Pan American Health Organization I mentioned already. So yes, there is quite extensive collaboration going on also outside the EU countries.
Thank you for that. Louise Woods, for your information, Dr. Rockenschaub is based in Australia, so hence I believe that's probably why she's inquiring about the efforts that might be carried out outside the EU.
So maybe then to add on to this, the Foreign Medical Teams initiative that I mentioned at the end of my presentation has been spearheaded by an Australian colleague, Ian Norton, who is actually seconded from the Australian government to WHO to coordinate this Foreign Medical Teams standardization. He is actually an Australian emergency physician and was also quite heavily involved in the response to the Typhoon Yolanda or Haiyan in the Philippines. So, of course, Australia is a major player in that particular aspect.
The second question we have is from Dr. Lathran, and Dr. Lathran is from Libya.
Yes.
And so, his question is inquiring about increasing awareness of the society in the to face such disasters and help medical staff so as not to increase the workload on them.
Yeah, thanks to Dr. Lathram. That's a very, very relevant point. And of course, the community focus is a major pillar in WHO's emergency work to promote community resilience and preparedness of communities is really essential, because it's always the local communities that are on the front line when it comes to response in disaster and emergency situations. So there is quite a bit of work done in trying to get effective protective measures across to educate community members how to effectively protect themselves, also to work with the Red Cross system in communicating first aid competencies at the community level. That's a very important element. And then we do quite a bit of work to train medical staff. In fact, in our region and also in the Eastern Mediterranean region, where Libya is one of the member states, I understand, in the Eastern Mediterranean region, there are training courses to particularly familiarize health professionals with emergency management competencies and expertise, so to train them in triage mechanisms and how to shift from a standard mode of operandi to a crisis mode that is required to effectively address the challenges in an emergency or mass casualty situation.
Thank you very much. I would invite any other people, any other participants who has a question.
There is one question I see from Eric who wanted a quick comment on how our work relates to the ICRC Healthcare in Danger initiative. In fact, there is a quite close collaboration between WHO and the International Committee of the Red Cross and Red Crescent Societies, particularly to address these really disturbing issues that increasingly in conflict situations, health facilities and health staff get into the front line or get caught between the front lines, and increasingly health facilities are attacked, ambulances are attacked, health professionals are attacked in conflict situation. There is actually quite a bit of work ongoing in WHO to create a common standard to try to, first of all, document those events a bit more standardized based on work that has been done in the occupied Palestinian territories, but also in other conflict situations. we try to create a database to better document those instances. And there is very close collaboration with the ICRC and their healthcare in danger initiative in that respect. And also, by the way, in this foreign medical teams agenda, I think I have been cut off somehow.
No, it's okay.
Okay.
You are online and your microphone is functioning.
Oh, it seems that my screen turned black, so I'm not seeing anything at the moment. But I'm trying to fix that.
We can see you.
Yeah, now I can see again. Yeah.
Okay, good.
So I hope I could address Eric's query in that respect. So just to confirm that there is close collaboration and coordination with the ICRC on both the healthcare in danger and on the foreign medical teams agenda, and of course on all our emergency work efforts.
Thank you very much. And Eric, I've been referred to, is obviously our, Eric de Rodenbeck, the IHF CEO. Does we invite any other questions, if there are any? Otherwise, we'll allow Dr. Rockenschaub maybe to make a final comment on this. Yeah,
I mean, just to underline that I would really like to thank Eric, Sheila, and James, and the whole team in the International Hospital Federation for inviting me to this webinar. We are, of course, from the WHO side, we are really delighted that I think this collaboration is getting some new momentum, and I'm just looking forward to further collaborate along those lines. I think there is a lot of commonality in our work, and if through increased collaboration and work together we can get some of our messages across to hospital managers, to the hospital community, for us in WHO, that's really essential, because that's really a target audience that is quite important for us. So thanks very much for your attention. It was a pleasure to be part of this, and hopefully it wasn't too boring for you.
Not at all, not at all. And I'm sure I'm speaking on behalf of all the other participants. Well, once again, thank you very much. And Dr. Rockenschaub, for your presentation. And we have a final comment here from somebody, Ursula, that indeed the information has been very useful. So want to carry forward. She's from the American Hospital Association in the USA. So thank you again for this presentation on an issue that certainly is deserving increased attention and exposure to, as you mentioned, our network and our target audience, and within the wider international healthcare community. And I would like to thank again all those who've participated in this webinar from all different corners of the globe, in spite of the pleasant and not so pleasant time zones they've had to handle. So thank you again. Just 3 brief announcement points: that the recording of this event will be posted on the IHF website. We will send through information about this to participants. And also, we would appreciate participants responding to a survey, which we will send out to help us improve our management and hosting of future webinars. And finally, that the next webinar is planned for September, and information will be sent out in due course. So again, thank you very much, Dr. Rockenschaub, and all participants. And
thanks
we
very much.
wish you all a pleasant weekend.
Yeah, the same to you, and thanks very much for your attention.
Thank you. Bye-bye.
Bye.